The patient is Ahmad, a 40-year-old smoker presenting with severe repeated vomiting. He has a refractory gastric outlet obstruction caused by a chronic duodenal ulcer. Before planning any surgical intervention, we have to look at the endoscopy results. Crucially, all biopsies taken from the site are negative for malignancy. We're dealing strictly with benign ulcer disease. Medical management has reached its limit. 2 separate trials of endoscopic balloon dilation have failed to maintain pyloric patency. This setup dictates the operative viva. The examiner is testing your ability to recognize when conservative options are exhausted, requiring you to synthesize a safe surgical plan. Your first priority is detailing the clinical history. Establish exact vomiting duration, calculate recent weight loss, confirm non-bilious vomitus, isolating the preampular ampullary. On physical examination, you are looking for a succussion splash, indicating a massively distended, fluid-filled stomach, and the systemic signs of severe dehydration. Identifying the irreversible mechanical obstruction at the pylorus confirms that medical management is no longer viable. Without surgical intervention, the patient remains in a cycle of chronic vomiting and progressive metabolic decline. A common pitfall in this station is rushing to surgical intervention without addressing the profound metabolic consequences of chronic vomiting. Notice the classic metabolic derangement, dropping chloride and potassium and rising blood pH, causing hypochloremic metabolic alkalosis. The patient loses massive gastric acid. To compensate for volume loss, the kidneys excrete potassium to conserve hydrogen ions. The grading rubric demands a strict 4-point preoperative preparation checklist: obtaining informed consent, confirming NPO status, inserting a nasogastric tube, and initiating targeted IV fluids. The nasogastric tube provides essential mechanical relief. It decompresses the dilated stomach, reducing the risk of aspiration during the induction of anesthesia. The intravenous fluids restore the depleted intravascular volume and provide the precise electrolyte replacements necessary to reverse the alkalosis. Demonstrating methodical metabolic optimization proves clinical safety before the scalpel touches the skin. Transitioning to the intraoperative phase, you confirm a standard midline incision to ensure maximum exposure of the upper gastrointestinal tract. The examiner will then ask you to articulate your surgical approach. The choice is an antractomy with either a Bilroth 1 or a Bilroth 2 reconstruction. Here is a vector comparison. A severely scarred duodenum makes a Bilroth 1 anastomosis impossible, placing high tension on compromised tissue. The Bilroth 2 bypasses the area entirely. To ensure a tension-free repair, you confirm the Bilroth 2 utilizing the Polya gastrectomy approach. Now you must list the rapid sequential operative steps required by the rubric. Step 1, evaluation of the duodenal pathology. Step 2, dissection of the greater curvature. Step 3, isolation and division of the left gastric vessels. Step 4, division of the stomach, completing the antractomy. Finally, the duodenal dissection. You must explicitly state the absence of advanced pathology beyond the bulb, which allows for the safe division of the duodenum. Reciting these steps rapidly and without hesitation establishes technical competence and spatial awareness. We arrive at a high-risk technical phase of the operation, the management and secure closure of the duodenal stump. You must list the 2 acceptable closure methods for scoring: the application of surgical staples or precise hand stitching. Poor technique at this specific junction leads to a duodenal stump blowout, leaking bile and pancreatic enzymes directly into the abdomen. Secure closure is imperative. You transition to the reconstruction phase by executing the gastrojejunal anastomosis via the Polya technique. The technical options for creating this anastomosis mirror the stump closure, utilizing a stapling technique or relying on hand stitching. The mechanical goal of the Polya reconstruction is to restore functional gastrointestinal continuity, bypassing the diseased duodenum. You complete the operative station by outlining the final procedural requirements, placing surgical drainage, and performing a layered abdominal closure. Choosing a tension-free bypass over a high-tension primary repair in the presence of scarring prevents the ischemic complications that lead to anastomotic failure. Post-operative care starts with protecting the repair. The protocol mandates continuous nasogastric suction for several days. The strict clinical criteria for resuming oral intake is objective evidence of the return of normal bowel function. Once eating resumes, you must provide the specific dietary counseling required for the first 4 to 6 weeks following gastric resection. The macronutrient profile must shift. The diet should be low in carbohydrates and fluids, but high in protein and fat. High carbohydrate meals create a rapid osmolar load entering the jejunum. This triggers a massive fluid shift from the vasculature into the bowel lumen, causing early dumping syndrome. To prevent this, liquids must be separated from solid meals, delayed 1 hour, and sweet drinks avoided. The gastrointestinal tract does adapt. After the initial 4 to 6 week period, patients can typically transition back to an unlimited diet. Meticulous dietary compliance prevents dumping syndrome, proving that surgical management includes physiological oversight after the operation concludes. The final question in the viva requires identifying the specific early and late complications of the Bilroth second reconstruction. The severe early operative complications are a duodenal fistula from a stump blowout and acute pancreatitis resulting from the dissection. The primary mechanical early complication is gastric outlet obstruction, occurring at the newly formed gastrojejunal anastomosis. The late complications begin with alkaline reflux gastritis, caused by bile washing into the stomach remnant. This vector schematic demonstrates afferent loop obstruction. The bypassed duodenal limb backs up with biliary and pancreatic secretions. It expands under mechanical pressure, resulting in afferent loop syndrome. The remaining long-term complications required by the rubric are marginal ulcers and systemic malabsorption. Malabsorption occurs due to rapid intestinal transit times and the bypass of the primary duodenal absorption sites for iron and calcium. Achieving full marks in this operative viva requires proving the ability to anticipate and manage the physiological consequences of altering human anatomy.